So we'll be heading towards our session 1 without any further delay, and this session is about the pain education and interdisciplinary approach. For this session, I would like to invite the chairpersons, Dr. Salman Salim. He's the Chief and Head of Department of Pain Medicine and Associate Professor at Shifa International Hospital, Islamabad. Sir, please come on the stage. He'll be joined by the co-chair, Professor Dr. Wasim Ismat Chaudhary. Dr. Wasim Ismat Chaudhary is a seasoned anesthesiologist with over 40 years of clinical and teaching experience. Formerly serving at Sheikh Zayed Hospital, he currently practices at Farooq Hospital, Westwood Branch, Lahore. He received his pain management training from Pain Relief Foundation, Walton Hospital, Liverpool, UK. In addition to his extensive medical career, Professor Chaudhary is an accomplished author with multiple publications and most recently his book called One-on-One Anesthesia. Welcome, sir. For the first talk, I would like to invite Dr. Clare Roques. Dr. Clare worked as an NHS consultant in anesthesia and inpatient pain management for over 15 years. During this time, she completed her PhD in social science and medicine on global aspect of pain management. She is a founder member and previous chair of the Essential Pain Management Advisory Group at the Faculty of Pain Medicine of Royal College of Anesthetists and previous chair the Pain Management Committee of WFSA, that is World Federation of Society of Anesthesiologists. She has led EPM program in many low and middle income countries and oversees its rollout in medical school across UK. Since leaving clinical practice in 2022, she has worked as a consultant for Global Health Partnership Charity and she is a clinical advisor to NHS Injectable Medicine Guide. Today, Dr. Roques will be talking about global perspective on pain education. Please welcome Dr. Roques.
Thank you very much for that kind introduction. I've realised how old that photograph is. I hadn't realised. I've gone much greyer since then. But it's nice. I like it. I like to look a lot younger. Thank you very much. And thank you very much for inviting me to speak here today. It's the third time I've been invited to come to Pakistan and only the first time that I've managed to actually get here. So I'm really pleased to finally be here. Thank you very much to everyone. As we've just heard, I'm from the UK. This is where I live. Well, I don't live in there, obviously. This is the town that I live in, Windsor in the UK. Very cold at the moment, so it's really lovely to be here in the warmth of Pakistan and also to have your incredible warmth of hospitality and the fantastic food I'm just getting to try. I don't need to go into the background of where I've worked because you just heard that. What I'm going to do is I'm going to speak a little bit, as Mary has suggested, on why we need improved education in pain management, why I think we do. Should I sit a bit further forward? Can you hear me? Okay, thank you. I'm going to talk about Essential Pain Management, EPM. It's an educational program that I've been involved in. Many of you know it here, I think. But for those of you who don't, I'm going to speak a little bit about it, about its history and its growth, and hopefully some of the future directions, and hopefully encourage some of you to get involved where you might want to. So just to give some background on the numbers on acute pain, it can be difficult to get global figures, but we know that over 50% of people have severe pain after surgery and trauma. From some WHO numbers, we know that about 10% of the world's deaths are due to injuries. And from a Lancet Commission report looking at improving access to global surgery, if we were to perform all of the procedures that we'd need to, so that would be increasing a lot of the provision in low and middle income countries, we'd need around 143 million more surgical procedures. So acute pain is a problem now, and it's likely to get more of a problem in the future. Chronic pain, again, it's quite difficult to get the prevalence on a global scale, but the numbers from different countries seem to come out quite repeatedly at fairly similar numbers. So a prevalence of probably around 20 to 30%. Palliative care, as I'll talk a little bit about that in my other talk, is actually quite a lot better research, and there's a lot more data that we have on global figures. This is from another Lancet commission suggesting that over 60 million people are in need of palliative care, the vast majority of them in low and middle income countries. So there's a huge need there. And this slide, again, I'll talk a little bit about it in my next talk, but this is again from that Lancet Commission, and it just highlights another problem around why I think we need better education. So this slide here, this map, is looking at access to opioid analgesia, and the size of each country here is distorted in relation to the amount of opioid that's available. So it's showing two things here. One is the gross overuse, in particularly here in North America, and the other is, of course, the severe underuse in all the countries that look very small. So that's the low-income countries. So there's two problems here, I think: opioids being overused and opioids being underused. So that's one thing that we try to look at a lot in our education. So I hope I've shown you that I think we need better education, and we need it across the globe in all different regions. And essential pain management is one of those programs that has been built to use in all these different environments. It's an off-the-shelf package. It works like other short-term courses that you may be familiar with here, things like PTC, so that's looking at trauma care, SAFE, which is looking at anesthesia provision, and ALS is something we have in the UK. I don't know if you have it here, but many of you will know it, I know, if you've worked or visited the UK. And that's looking at life support training. But the point is that it's a pre-made package. It's there, easy to use. Ours is free to use. It's for all healthcare workers. And the idea is to improve knowledge, but to provide a simple framework. So it's a system, and a system that can be used in every different environment. You can change it as you need to for your own environment. And one of the really important things we also do is not just teach our model, but we have a very good session, I think, on barriers, which is trying to find out from people where they work what the local problems are and what might be possible to be done to overcome those barriers. So we make it a very interactive session. This is one of the courses in Zambia that we've done. It's a one-day course, but in its most basic format. We start with lectures, but we try to make them very interactive. We have a fairly small group usually. We do case-based discussions. We ask people that you can choose which cases you do, so that you have cases that are relevant. And as I said, we talk about barriers as well. We also usually, when we go to a new country, or new region, we will run a one-day workshop, usually for quite senior clinicians, so people who know the content. We're not teaching content, we're teaching them how to use the system. And then on the second day, we'll do an instructor's workshop for them, just to teach a few more of our principles. And then we'll go into straight away running a workshop or a set of workshops with the new instructors immediately teaching. So we run quite quickly with a 1/2 usually, or even more than that sometimes. We use an acronym of RAT, and we use that to explain the need to recognize first that patients have pain, and then talk about how to assess it and how to treat it. And the reason we choose the RAT is because, like pain, RATs are unpleasant. They're often unseen. You have to sometimes look quite carefully to realize that they're there, but they can often be treated with pretty simple and cheap measures if we bother to do so. So I'm just going to show you a few of our example slides so you get the feel of the sort of bases of what we teach. We teach in some ways, some quite complicated concepts, as Mary was just talking about, the sort of wider issues around pain management, but we do it in a simple system so that it's easy to understand. So we talk about the benefits of treating pain, not just for the individual, but for family and society. And those are the sort of things that obviously help to encourage our funders to address pain and to let us do what we want to do. We talk about severity, about assessing the severity, and we assess in many different ways. The point about this slide is that we will encourage people to teach whatever systems you have where you work. So it might be a verbal scale, it might be a visual analog scale, it might be a 5-finger scale. There's all sorts of different scales, but you can teach whatever scale you use and whatever's most appropriate for your staff and for your communities. We talk about classifying, and we try to stick to these areas of classification because they very much affect what treatments are going to be effective. So we talk about distinguishing between acute or chronic pain, so anything that's short-term and is going to go away, or anything that's going to last. We talk about cancer and non-cancer pain. Really what we're meaning is pain at the end of life, or pain that's curative. And then we talk about nociceptive and neuropathic. So this, as I said, is because we want to make sure that we're treating acute pain or pain at the end of life will be amenable to opioids. Chronic non-cancer pain is not going to be amenable to opioids. And neuropathic pain, obviously, it will often need a different line of treatment. We do go into physiology, and we teach some basics because we don't want to put off some people. The doctors often quite like the physiology, certainly the pain specialists. But we make sure that we teach some basics so that people understand the basic principles around modulation and why there might be changes to patients' pain depending on what's going up at a higher cerebral level. But we don't want to overwhelm people too much in case they're not very happy with some of the physiology. So we put this in there so it's a good basis, and you can teach it to a higher level if your students want that, but you can keep it simple as well. As I said, the different treatments that we might need for different types of pain is really important, and we do particularly make sure that the way we describe the use of opioids is very clear, so that they are effective for cancer pain and pain at the acute pain, but that they are not usually appropriate for chronic non-cancer pain. And as I said, we talk about barriers. We try to make it very interactive and to get local people to start to think very practically about what the problems are, where they are working, and what they might be able to do to overcome them. This is one of the cases that we use. So obviously, if you have a quick look at this, this is a man with acute pain, acute nociceptive pain. But as I said, we have lots of different cases that you can pick from. We try to encourage you to teach a variety of patients, of cases, and different types of pain, but we will have different cases that may be more appropriate in some regions. So if we're going to parts of Africa, we will introduce cases around sickle cell disease, for example. And if you're working in a pediatric setting, there are pediatric cases as well. So I've got the same slide as Mary, which is nice to see that that's come together. This is from a few years old, but shows that the spread of EPM. The next slide is always out of date because by the time I've decided to say how many countries we've done in EPM, and it's that there's a few more. But EPM was originally written by Roger Ghurki, who also appeared on one of Mary's slides, and Wayne Morris, who are doctors working with the Australian and New Zealand College of Anaesthetists. And it was first written to be used in a low-income setting. It was used in Papua New Guinea, where they first introduced it back in 2010. But increasingly, people have realised that it's useful for all resource settings, whether they're low resource or high resource. It's been run in many, many countries. It's been translated into lots of languages. And we have a great new resource, actually, called EPM, and I'll put a link up at the end. But this is an online version. It's free to access. You can understand all of the background and all of the training materials that we have. You can go through a whole load of sessions and a whole load of cases. What it doesn't have is an interactive component, but it's a very good background resource. And then after that, you can go on to do some group work. It's grown in its administration as well. So now we work with the WFSA, the World Federation of Societies of Anesthesiologists. So that's the umbrella group for all national anesthesia societies. And they now are overseeing the steering group, so the work of EPM across the world. In the UK, we have an advisory group at our Faculty of Pain Medicine at the College of Anaesthetists. So I'm just going to speak a little bit more about that, and just give you an example of the work that we've done and hopefully show how that can be applicable to other settings as well. So really what we do, we usually really just coordinate our UK instructors. We sometimes put a little bit of funding in. Usually we get that from outside, or we encourage people to be running the courses without needing any additional funding. I've been more interested or more involved in the overseas work, and we have introduced EPM to many countries across Africa with Usman, who I can't see at the moment. There he is. And Gauhar have introduced EPM here to Pakistan, so they will be able to tell you more about the work here. But we've worked in partnership with many other charities as well, so Mercy Ships in Africa, the Tropical Health Education Trust in the UK, the WFSA, as I mentioned, and our Association of Anaesthetists. They've all funded some of our work. But just to finish, I'm going to talk a little bit about how we've introduced EPM to the UK, as I said, to give you hopefully some ideas about how you might be able to use the resources. So we started in the UK in 2014 with a programme called EPM Lite, which was originally designed to be used in high-income settings, actually with almost entirely the same resources, except we took out the barriers section because we thought when we were teaching medical students it wouldn't be so important for them to be able to think about how they might change the institution where they were working. But actually we're moving away from using a different terminology and just using EPM. The work hasn't been done by me. I've just been, was chairing some of the work, but I must give credit to other people, particularly Helen, who led on this in the UK. So she started at one medical school in Bristol. We had a very, very relaxed approach to how we were going to do it. We just asked volunteers, went through word of mouth, put a couple of key requests out in some of our newsletters. And we went for what Wayne, one of the founders, would call the low-hanging fruit. So if a medical school said, no, don't worry, we've got our own course, we want to do that, we said, that's fine, you keep doing what you want. But if you want a resource, you can have ours for free, and we will help you implement it as best as we can. So as I said, we changed the name. We moved to EPM UK because people were thinking they were just getting EPM Lite and they thought, oh, it's not the full EPM. But it is using very much the same materials. So we call our work EPM UK. And we've grown to a network of nearly all medical schools in the UK, certainly the majority of medical schools. We very much, as I said, went for a bottom-up approach. We have involved some of the higher level organisations, so our Medical Schools Council and the Foundation Programme Directors team. So the Foundation Programme in the UK is, for those of you who don't know, is the year or two after qualification when our junior doctors are more heavily supported from an educational point of view. So we've worked with them to try to network how we implement EPM, but we've really worked from growing from the bottom. We just have sort of commendation really, or acceptance from these higher levels, which has been very helpful. We've also moved beyond teaching medical students to teach some of our trainee doctors, both medical, surgical, anaesthetic and GP trainees, and where necessary we've modulated our programme to be teaching those different groups. And the final bit of work we've done is working through institutions. So that's much more of a multidisciplinary teamwork. So, for example, if we have an acute pain team in a hospital, which is led or run mostly by our nurses, they will often run educational programs within the hospital, and they will be teaching pain nurses, maybe physios, all sorts of different groups of people will come together, and we will link that in with the teaching for the junior medical staff and the senior medical staff as well. So there's different approaches to that. The other thing we've done, which I think is really important to know when you're thinking about getting involved in EPM, is, as I said, we try to run EPM as a one-day course or maybe as a half-day course if you take out the barriers work. But actually what we did was we enabled people to run EPM in whatever way was going to work. So I'm sure it's the same here. People will often say at medical school, oh, there's no space in the curriculum. We can't possibly do a whole session on pain. But we've got maybe an hour a week that we can have have the medical students for, we said that's fine. If you've only got an hour a week for maybe over 6 months, then break up EPM and make it fit into that system. And you can just do an hour one week, an hour another week. Or, as I said, we can use the online version that we have so that people can do all the background work beforehand, and then when they come together and they have one-on-one group teaching sessions, that we can then spend the time working on case-based discussions, which is more important to be having group work. And we now have a system of regional leads. So this is across the UK. For most regions, we have somebody who coordinates that work so that we can disseminate and cascade how things are delivered. These resources, they're available here on our website. I'll put the link up again at the end. But if you put EPM, FPM at the Royal College of Anaesthetists into Google, you'll find it pretty easily. And we have a modified slide set, so that will give you an idea of how we will change how we deliver EPM for our group. So if we're teaching anaesthetic trainees, then we will want to put in more complex cases and build on some of the foundation work. If we're teaching surgeons, then we will teach that in a certain way and tailor things a little bit. As I said, there's complex cases which give you an idea of how you might modify things for your trainees. This, I'm afraid, is just an NHS available resource. That's different to EPM. So ePain, don't worry about that. That's just NHS. But EPM is available for everyone. There's a video which is interesting to hear a personal experience about how EPM has been introduced to their hospital. And there's also an example of how we've used the EPM resources to link in with other objectives and other curricula from other parts of our training system. So again, you can see how you might develop things to fit into your own scenario. When we think about evaluation, these are different things that we've used across different parts of our implementation. So we can use MCQs. Sometimes they're popular, sometimes they're not. We obviously always get feedback from our teams, from our participants and instructors. We have at certain times, I was involved in a program in Uganda when we did staged MCQs. So we looked at the results of people's tests immediately after the program, but we also looked at afterwards, several months after, to see if people were maintaining their knowledge or whether we needed to go back and give some booster sessions. We've done some qualitative interviews with lead clinicians, a thing called commitment to change. So that's asking people about how their practice has changed, because it can be quite difficult to find out exactly how things have changed. And then linking in with some of the work on barriers, we do really try to encourage people to link in the work of EPM with some clinical initiatives. So maybe as simple as looking at the audit of your own services, but really trying to make it about service provision as well, not just about the teaching of individuals in the classroom. So, of course, again, I couldn't do this without everybody else. This is one of the teams that we worked with out in Lahore Hospital in Uganda, where we did some of our longer-term work looking at the evaluation and sustainability. And we've run many, many EPM courses now in Lahore and Uganda. So in summary, I hope I've shown you that there is definitely a need for improved education. I don't think I probably need to persuade you, but we do need it at a global level. And often we can use the same resources in many, many different environments. I think going back to basics is the really important thing. EPM is one of those models. We go back to basics and we build up from there. It's tried and tested and is getting more and more popular around the world. Adaptability is very, very important to us, as is sustainability. So I'd encourage you all, if you do want to get involved, there's many resources here, or just come and ask me. And it's very easy to find on Google, essentialpainmanagement.org. And you can find all the information there that you need. So thank you very much.
Thank you so much, Dr. Roques. Now we're heading towards our next talk. For our next talk, I would like to invite Dr. Athar Siddiqui. He is a consultant anesthesiologist at Evercare Hospital, Lahore, Pakistan. He is an expert in acute pain management and obstetric analgesia, and he has worked in NHS as consultant for decades. He is a researcher and has many publications to his credit in regional anesthesia. Dr. Siddiqui will be displaying a snapshot of acute pain services in Lahore today. Please welcome Dr. Siddiqui.
Bismillah ar-Rahman ar-Rahim. Thank you very much to the organizers to provide me this opportunity to talk about the local perspective of acute pain medicine in Lahore and broadly in Pakistan. So it's always very difficult to talk about any subject after the two stalwarts, but I'll try, and you will be the best judge to know whether I have done justice to my topic or not. So my talk will be actually based on two sections. One is a little survey which I have conducted in the various tertiary care hospitals in Lahore, both in the private and the public sector. And the other one is a little brief about our journey of acute pain service in Pakistan. So the first question arises that why we are bothered about the acute pain service, as that has been already described by Dr. Cardoza, that it is the basic human right. And this was the landmark paper which was published in 2007, which highlighted the importance of basic human right to treat the pain. So we live in a time where we are talking about the patient-centered care, and whatever discipline of medicine we are working in, actually we are quite well established as far as the scientific advent of the clinical application of the knowledge and skills are concerned. And we are all bothered about that what does that knowledge and our skill impacts on the outcome to the patient. So the patient-centered care is the slogan in the West, and that is the slogan in the developing countries as well. So the patient-reported outcome measures are the measures on which all the efficacies of the treatments, all the skill set of the clinicians and everything would be assessed, and they are being assessed. So about the patient-reported outcome measures, pain is a vital, important aspect. And there are many publications like this in which the importance of pain as far as the intensity of the pain, about the physical activity related to the pain, and about the physical function of the person after, in our field of anesthesiology, after having a surgery or after giving a childbirth or in any acute condition where we are treating the acute pain. I'm very pleased to refer this patient in the presence of the author of this paper, Dr. Clare Roques, who mentioned and who drew the attention of all the clinicians of the world towards that the most common causes of acute pain are peri and the post-operative patients, the trauma, the childbirth, and in the African world, the sickle cell disease. This is the local picture which I just wanted to highlight, and this is the Emergency Services Department from the Government of Punjab. And you can see over here that this data is for the last 20 years, and there are about 1 million road traffic accidents reported to them. And that counts around more than 1,400 cases a month, and almost 139 cases of road traffic accidents, they happen over here in this particular city of Lahore. And this city bears a population of 14 million. So this is the local picture. And the global picture has been highlighted by my predecessors, that the WHO estimates that 5.5 billion people, more than 80% of the global population, do not have access to the treatment for moderate to severe pain. And an estimated 28% of the global burden of the disease may be averted by the appropriate surgery and safe anesthesia. So imagine if the word is provided by the resources to the third world countries or the low and middle income countries or the underdeveloped world, then it means that there would be more surgical interventions, and as a result of that there would be more acute pain patients which we will be treating. So the post-surgical pain in a low and middle income countries, so basically that paper was published some times ago, and it highlighted exactly the same thing which I have just said in the previous slides. So in the field of the acute pain medicine, the other most important thing are the quality indicators. Whosoever is dealing with the acute pain, what are the modalities which are being used? What is the skill set of the people who are dealing with the acute pain? And we have learned a lot today about the biopsychosocial model of the pain. We have learned a lot about the multidisciplinary approach and the coordinated approach, may it be the acute pain service or the chronic pain. So the quality indicators is a large framework, more than 21 indicators in the field of acute pain services, which are now to be considered. And the survey which I conducted in my humble capacity is just an endeavor to sensitize the anesthetic fraternity of my city to think about the patient-reported outcome measures, which will be the talk of the town and which will be the talk of the future, vis-a-vis to the acute pain management. So I devised 9 or 10 questions, and the first question was that how often do you engage with the acute pain team in your hospital? And I sent this questionnaire to 25 teaching hospitals, out of which 13 were in the government sector, in the public sector, and 12 were in the private sector. And I picked up these 13 hospitals out of 27 tertiary referral hospitals in this city, because there were eminent professors and senior consultants who had more than 2 decades at least of experience in the subject of anesthesiology and the pain medicine. And I was very happy to receive the response from 20 worthy colleagues of mine. So 45% of my colleagues responded that they often get engaged with the acute pain service team, and 40% responded that they get engaged with them daily, and 15% responded that they get engaged with the team occasionally. The next question was, does your acute pain service team communicate effectively communicate daily updates to the rest of the anesthetic department for the continuity of the care? And 35% of my colleagues responded often, 30% responded occasionally, and 30% responded daily, and 5% responded rarely. So if I just go in and analyze this data between the first and the second slide, there are a few things which can be highlighted about it, that there may be some disparities in understanding the question, or I really can't say with certainty that why was that so. The third question was that how well you recognize the acute service team of your hospital collaborates with the other specialties such as surgical orthopedics, obstetrics, nursing, and physiotherapy department. Obviously, in the biopsychosocial model, the clinical psychologists are a very rare commodity in our part of the world, and the social services are barely unheard of. So the 75% responded that they collaborate fairly with the multidisciplinary team, whereas 20% responded good, and only 5% graded them excellent in collaboration with the other specialities. The next question was that are the pain management protocols practiced by your acute pain service are based on the evidence-based medicine? 75% overwhelmingly said some of these, whereas 20% responded all of them. The next question was, how would you rate your acute pain service team in your hospital to avoid post-operative complications such as inadequate pain relief and overuse or the underuse of the opioids? It was underuse of the opioids, and 75% responded fairly, 10% responded excellent, 10% responded good, and 5% responded poorly. The second last question was, do you practice safety procedures like WHO safety checklist, stop before the block, labeling of the epidural lines with the yellow stickers, programming of the pumps and the use of the anti-siphon valves for your PCA lines, and 70% responded, some of them, and 30% responded, all of them, yes, and the rest of the options, they were not clicked by anyone. Sorry, this is the second last question. Do you audit the outcomes of the acute pain interventions? Because that is the most important aspect which Dr. Cardoza highlighted as well, that we continuously need to audit and re-audit and complete the audit cycle about our practices and know that what we are really doing to the patient as the patient-centered care is concerned. So the answer was 55% said yes and 45% said no. And does your APS team educate your patients, their attendants, and other healthcare providers? That includes the education about the interventions with possible outcomes and complications. 70% overwhelmingly responded yes, 15% responded no, and 15% responded sometimes. And the last question was, what are the main challenges encountered to your acute pain service? And they were almost the same which both of my worthy learned speakers before me highlighted. So I enumerated that as the staffing issues, both as far as the doctors and the nursing staff are concerned. The equipment issues, the most important one is the ultrasound machines and the needles, and the rest of the equipment, the availability of the morphine, fentanyl, and the other opioids, which is an uphill task to get them in the hospitals, although there are plenty on the streets, and the organizational issues that the pain is an emerging specialty, and if an anesthesiologist is interested in doing the pain procedures, there are so many hindrances because it takes time, and we are always short of time, and our anesthetic work takes the priority, and unfortunately the pain part of the anesthetic procedures are still to be recognized by our surgical colleagues, and the rest of the option was all of the above or some of the above, and 35% they responded that some of the above, and 35% responded all of the above, whereas 15% responded the availability of the opioids is the main issue, and the 10% responded that the staffing or the issue of the manpower was the main concern. So what does this survey tell us? This survey tells us that we need to tackle the barrier in our own frame of working, in our own setup. And the most important thing is spreading the word of mouth. Education, education, and education. And collaboration with the patients. You must need to have some time to talk to your patients with the various specialties. I'm so happy to see my orthopedic colleagues joining us this morning, my urologist colleague, my surgical colleague, and the other specialties who are present, at least from my hospital over here. I'm so thankful for them for supporting us today in our endeavor towards progressing through the field of pain medicine. The effective pain management and presentation of its PROMs and QIs. That is the lesson for all of us. The patient-reported outcome measures, the patient-centered care is the answer. And the pain control is the most important one. And the quality indicators of the pain control is the take-home message. Then we need to continuously perform the audit and complete its cycles, and we must present it data to the rest of our colleagues as well. And we keep on striving for resource allocation as far as the staff are concerned, the equipment is concerned, and the medication is concerned. There were a few limitations of this survey. I will just skip that, and I'll come to the second part of my talk. How did we start the acute pain service in my part of the world? Please mind it, this is all anecdotal reflections, and I would start with the saying that it was all very subjective and very institutionalized. I must praise my worthy teacher, Brigadier Salim, like my other colleagues, Brigadier Asif Gulkiani and General Amjad. I was trained in mid-80s by him, and when we used to enter in his office, I used to see the hefty Bonicker's book, lying on the shelf behind his chair. And I used to wonder that on those early days, we used to have only one textbook of anesthesia, which is of Alfred Lee. Even the Hutchison's book was, a later entry into the curriculum. And it was considered that a moaning and a crying patient is a well-recovered patient. And the anesthesiologist did not have to worry about, his respiratory depression, his other aspects. So that was a norm. And it was a norm to take up a patient. Rather, I would say it was a taboo to know that if a patient had a surgery, he must have some pain. Then the other thing which was always there as a tug of war between our surgical colleagues and ourselves was the time and the cost versus the surgical time and the cost. Although it had always been a very meager part as far as the time and the money was concerned. However, that has always been there. And in those times, the regional anesthesia was considered as that whenever it was administered to the patient will usually be not attended by the anesthesiologist because we used to be so thin on the ground. So I still remember that we used to run 5 operation theatres in CMH Lahore, and at the end of the list, we used to have 4 hemorrhoidectomies, all patients laid down on the operation tables in the left lateral position with the drip on, and I used to go bang, 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 caudal anesthesia to all of them, and then I used to go for my ICU round. So that was, the sort of background. And then the change started trickling in when my teachers like Brigadier Salim and others, they started coming into Pakistan after getting trained in the United Kingdom, usually, and they were able to talk at the same level with our respected surgical colleagues. And they were able to penetrate, inside the thick wall through sheer their convincing attitude. And one of my colleagues, Brigadier Safdar Ali Khan, is sitting over here. I call him Bhai Miya Muhabbat Fateh Alam, that he can do anything with his very lovely, mannerism, and he can convince anybody. So I must refer over here the Yasser Arafat, the famous Palestinian leader who said that confidence doesn't alone make peace, but acknowledging rights and confidence do. So that was the technique which our teachers adopted. Then they started presenting the pain intervention outcomes to our surgical colleagues in the massive clinico-pathological conferences which we used to have. So as it has been talked about by Dr. Cardoza earlier on, the first thing what we really need to do about establishment of an acute pain service, if I just, put the jigsaw puzzle together, is the first thing is the health need assessment. So we need to identify the demand. We reviewed our patient population, we evaluated the trauma patients, we volunteered to be the part of the trauma team, and that is how we infiltrated into the acute pain service. And then we highlighted the benefits by presenting our data. That is the most important aspect. Whatever laurels you are bringing to your specialty, you must present it. You must show it digitally that what really you are doing, and that is the thing which is being done in the Western world today. Then we had to make the guidelines. In those days, the British Journal of Anesthesia used to be the only way of communication between us and the United Kingdom. And now, on a single click, you can download the whole of the guidelines and you can adopt them into your own hospital. The team structure, then the multimodal pain management program, and the training and the education, that is the most important aspect. And we have to integrate with the rest of the specialties, and then we have to gradually expand. So this was a picture which was taken up in March 2018 when the EPMS was launched by my very dear Dr. Osman Bashir over here. And that was the picture of the master trainers. And majority of us, we are over here today, except this gentleman in the middle who is just standing beside me. He passed away in COVID. This gentleman, may God bless his soul. And that is another picture of the same faculty. And that was in October 2018 when we conducted the first EPM course in Shaukat Khanam Hospital when I was working over there. And that was the faculty member over there. So in the end, I just wanted to highlight a lot of other aspects that what's really going on the acute pain horizon. And just for those budding up anesthesiologists over here, that probably soon you'll be using these Neurolite, this LG scan, and this pain assessment using the analgesia nociceptive index, which is coming up, and they are nothing but the improved version of our simple clinical tools which we normally use each and every day. Thank you very much.
Thank you so much, sir. Now we'll be heading towards our last talk of this session. For that, I'll request Professor Dr. Leena Aziz. Ma'am, please come on the stage. Ma'am is a professor of anesthesia since 2018. She is supervising FCPS and MCPS anesthesia and second fellowship program in pain medicine. She is also an examiner, and her special interest in pain medicine with many publications on pain medicine and regional anesthesia. She has the honor to have the pioneer publication on tap lock in Pakistan, and currently she is heading the Department of Pain Medicine and Anesthesia at Ghurki Trust Teaching Hospital. Ma'am will be discussing pain education in Pakistan, past, present, and future. Please welcome Professor Dr. Leena Aziz.
Bismillahirrahmanirrahim. Rabbi shrah li sadri wa yassir li amri wahlul 'uqdatam min lisani yafqahu qawli. Most of my work has already been done by my worthy presenters. Primarily, Brigadier Kiani has done quite a bit of work for me. And the rest was done by Dr. Athar and all the other distinguished speakers. Anyway, I'll try to sum up as much as I can. The topic assigned to me and what is the current situation, what has been in the past, and what do we see in future, and how can we improve of it in Pakistan. Actually, the situation which we come across has been coming across ever since. It was that, if I just share a small note with you, a fourth-year medical student got a whiplash injury to the neck 8 months ago. She developed severe pain and was given the usual treatment of NSAIDs and eventually to the opioids. The WHO letter was followed, mild, moderate to severe, and in 1 to 2 months, they became a wreck out of that little girl. And her social life was quite at stake, and the family and whatever it was, she ended up in a real mess, that poor girl. And what so many things, and she went for intervention, which is the thing which we are doing, and we are so very fond of doing it nowadays. And what should have been the proper treatment and proper approach to that girl might have changed the whole attitude towards whatever made out of it. And this is exactly what is happening with the pain education, pain medicine, pain practice in our country nowadays. Now, she became a social unfit and was unable to promote whatever life she was doing. So we've got to see where the pain education is a problem, how she should have been treated, and how we were supposed to tackle these patients from day-to-day life. As you know, pain physician is expected, dealt at such a detail so far by the end of my session. I mean, it's just like a tree with all the branches, with occupying so many things, which is labeled as pain. Pain, yes, it's a presenting complaint. We say patient come to for medical help whenever there is a pain. In fact, it is the pain which he comes from, and it is the end result he wants that the pain should go away, irrespective whether it was surgery or whatever it is. It is a presenting complaint. It is the recovery stage itself. So it has to be dealt from all aspects. A pain physician, as we have just talked about it over and over again, has to be a very good psychologist, where to get psychologists in our part of the world. And it was a little heartening to know that it's a global problem, not only in Pakistan, but it is a problem which is being faced all over. And then a touch of behavioral scientists, the pain educationist. So it's a complex thing which has to be dealt. And what are we supposed to be doing? As I mentioned, it is a multifactorial, and the brain creates pain from many factors, and it is a complex thing. It has not been understood fully, as you can say from the other diseases. It is a complex thing. The root of every disease, the root of every specialty, if pain is addressed, the patient is healthy. The patient comes back to the normal life. The patient is adjusted. And what are the problems if the pain is not addressed? The social, the economical, at the patient's level, at the global level, at the country level. What is expected? It is a holistically approach which we want to have. And as we said, the pain intervention is on the top. Physical therapy, antipsychotic. And the problem nowadays which we are facing is, because of the interventional pain, the treatment and the supports of the radiology and other things are also coming into it. And now the trend is to treat the X-rays, the MRIs, not the patient. So I don't think so. It's a very healthy approach. We need to tackle it, and we should be aware of what is happening. The holistic approach has quite a bit ceased. What was the past practices in our country? Just now, it was given a detailed account that if a patient is going for a surgery, it was expected that in the recovery, if the patient is not yelling with pain or moaning with pain, then there is something abnormal. And for the recovery from the anesthesia point of view, it was a good parameter. The patient is awake, yelling, groaning, whatever it is, the patient is out and it is fully okay. And when you come to the obstetric units, the labor pains, it used to say, the more the labor pains are experienced, the more the agony a mother goes in, the better the mother is. That was the concept. Still is in many parts of our country. Similarly, any procedure in which if there is no pain, it is not considered that the procedure is successful. Then, with the passage of time, narcotics were introduced. As it was just discussed that on the streets, it is very much on the high. And then what are these spiritual people, where most of our people are going? Why is it so? I analyzed it, that there is definitely a problem coming us with our medical people. We don't have enough time. We don't listen. Why these spiritual healers are on the high? Because they know the psychology, they know where to start, what to talk about, what is the background. Even if you go to Haveli Lakha, it is so much in demand and it is getting fruitful results. Why? Because they are playing with the psychology of the patients. Unfortunately, we are when treated for the FCPS, we have 3 days communication skills. 3 days communication skills workshop is not enough to deal with such a big problem. This thing should be addressed right at the undergraduate levels, at our teaching levels. The empathy should be dealt with. And we have got to see what is the problem and why these faith healers are getting so much of attention as compared to us. Well, what are the courses which are being given? Dr. Kani has dealt in detail, which are at the present. We are training the pain and pain participants and the pain teachers and how to go about it. This is just a nutshell of whatever the teaching so far is being given. As a 5th vital sign, we know that it has its own importance, but actually what is to be taught at our college levels, at our medical school levels is, yes, it's a 5th vital sign to begin with, but we've got to know what the pain is to get over this pain problem. It is inevitable, but suffering is not optional. We've got to teach, retransform all our people, primarily at the medical school levels. Presently, what is the problem which the pain physicians are facing or why this change has come over. I personally see that the intervention pain has gone quite high. We have pain physicians and now we are having pain surgeons. The problem is that in the medical schools, the teaching is very limited. The curriculum is inadequate and the time for curriculum is also not enough. There is no standardization currently. There is a difference of opinion between different pain physicians, which needs a standardization, which need a control or ruling body to see as what and how are they going about. We have no regulatory authority at the moment. And the use of interventional procedures is tremendously on the rise because, as it was just mentioned, they are immediate results and immediate financial results also, unfortunately or fortunately. And so the misuse of these intervention pains, which are self-learning in many cases, not guided by many people, not by a system, it is producing quite a bit of a problem currently. There is a mushroom growth currently of the pain clinics. Anybody who would like to have a graduation of MBBS is trying to get into this pain clinic business, irrespective of any control. And the anesthetists, though they are the best people to do it because they are trained and they can get over all the problems which there is any anaphylaxis or any reactions or anything, they are the best people to do, no doubt. At the same time, they have a command over their clinics. They are not subjected to what in the anesthesia practice, unfortunately, dictated by their colleagues. And the financial returns are also not that lucrative as it is in the pain medicine. So this has a good point as well as a bad point. So we have to see all these things, though this is coming up, but the patient's sufferings and the patient's satisfaction is not actually addressed. The referrals are very, very little. The multidisciplinary, as we talked about, this specialty is multidisciplinary. It is non-existent practically in our part of the world. It should be done. It should be multidisciplinary, integration, and we should be able to teach the youngsters that they should be able to see out of the box as well. The problem is not the nociceptive or neuropathic. We see it as the nociplastic pain which has to be addressed the most in this problem. And it has been overlooked and it needs to be addressed. And the patient's rehabilitation has to be done. And in many cases, we have seen if the patients are counseled properly, the interventions are definitely not the only way out. In 2018, it was declared the Global Year of Excellence for Pain Education by the IASP, and multidisciplinary approaches were coined. The pain priorities, 30% presenting complaint is pain. I think it is even more than what has been documented. And what are the effects? Obviously, the patients' absentees, their own personal lives, their workplaces, everything is affected by this pain, and the patient are not able to cope up or adjust to their normal life. And the pain physicians and the pain surgeons, this balance has to be taken into account. What should we do in the future? There should be a curriculum for treating the acute as well as for chronic, and it should be beyond pharmacology. And multidisciplinary approaches, so it should be a socio-psycho-bio model. So far, we've been talking about biopsychosocial, but in practice, what I've seen, it is better to go for socio-psycho-bio model. And we've got to have the credentials and privileges monitoring of the physicians. Only then that this threat bucket can be tapped. How do I see it in future? The awareness campaigns should be started, which are being done, but I think they should be more on the media, more in the collegiate levels, and more at the government levels, because majority of our population cannot afford to have the private treatments. The pain symposias, the pain conferences, a collaboration with the GPs and the general physician trainings has got to be there. We've got to get over the bias which is being existed. And the training of the paramedics, hospice centers are non-existent. The cancer patients cannot be treated by the family members. They need support. At least there should be some centers developed at the state level where they can get some help. The pain registry, it is non-existent in our part of the world. We've got to motivate, and we should introduce it, and we should launch it. Research-centered growth, and we don't have any pain journal in our country for this very specific thing. We got to go to the symposiums and the pain camps, etc. What is the future? We are talking of artificial intelligence and pain education time and again. We can develop these chatbots, simulation labs, pain clinic at tertiary care again. And the pain curriculum should be very, very comprehensive. We can do these awareness months and all these things which can bring a change in the outlook of the patients and the families. Actually, it's not one patient we are treating, it is the family in collaboration. The past biomedical model drugs and surgery should be replaced with biopsycho model and social psycho model from now onwards. We at Ghurki, the eastern part of our city of Lahore, it's quite a rural area. We are working there with a big team, and there we designed a model ourselves. We did not have the support of the psychiatrist time and again, and they were also short, they could not do anything. But we did not give up. What we did, we developed a model that instead of one person sitting in the pain clinic, at least 3 or 4 of us were sitting there. And when the patient would come in, each one of us was able to communicate with that patient and see the different aspects. And it did make a difference, and we think that it could be somewhat a replacement till we find a proper training in the psychiatric part, or we have to take this responsibility ourselves. Again, pain is an uphill task with lots of ups and downs. It's not a smooth journey. It will require a lot of patience, lot of resources, a lot of cooperation by the family. The family is the center point which has to be taken, not the patient, totally separately. September was the ISP Pain Awareness Month. What we did at our setup, we took care of about 550 OPD patients, and 90 acute pain blocks were done. 120 chronic pain procedures were done, booked in our theaters and followed up. So we are trying to create a model. I hope we are successful and able to contribute and help in the making up of the policies of our country. Thank you.
Thank you so much, ma'am. Now the house is open for questions before we conclude our session.
Professor Durrani from DG Khan. Sir, today we have a medical concern rising day by day. We need informed consent set by Pakistan or all over the world. I think I have never seen such a informed consent for whether pain is for intervention or non-intervention, pharmacological or not pharmacological. So we need this. I only saw a consent form developed by Rahimyar Khan. Anything else about it?
Very valid point. We should take consent before any procedure. We are taking actually. I think in our setup and many other setup, consents are taken. And this is managed like this. जहाँ पे नई consults ले रहे वहाँ पे भी उधर भी करनी चाहिए.
May I comment? So I don't know about if you're talking about the Punjab health system, but as far as I'm practicing in the Sindh area in the Karachi, I'm working here, and certainly one of the most important, the first thing is about the informed consent, and without informed consent we cannot go for any kind of intervention or anything else. You're talking about in the pain education. So certainly for pain intervention, we are talking about any kind of from trigeminal to anything. We have to inform, we have to take consult.
We cannot take our patient to OR without consent.
We cannot do any intervention, small thing without informed consent. So I think this is happening in majority of the country. If some part, I don't know about...
Any sample of consent form?
Yes, we have. Yes, we share with you. Yes, we share with you. And I think, I don't know but if anyone comment from Punjab side, because we have a very...
Actually, may I comment on this, Dr. Gohar? we have a consent form, but not specifically for pain procedures. But I think it needs to be incorporated. Maybe additional thing can be added to it. But no surgery, no procedure is being done without a consent
But we
form.
have a separate.
Yes,
so I
we
don't
have
know
separate.
what-
We can add to it actually.
We take consent for every procedure, even for trigger point injections. It is a routine. Informed consent with signatures.
Actually, the consent time can be taken as a period where you can actually counsel the patient as well, or psychotherapy or physiotherapy. That can also be done at that time. Maybe if it is extended up, along with the consent, you can have some talk with the patient and develop a rapport as well. Ji, kya hai, sir?
So this concept, as Professor Khalid says and Dr. Kaur says, ये जो है ना, in Punjab, the regulatory authority is the Healthcare Commission. So I have a little insight into there because I'm their external expert in that. So their requirement is Healthcare Commission that every patient in every hospital, first of all, they should have a general consent. We have to, every patient, not just pain patient, there has to be a general consent that I want to be treated, I am ready to be, I'm willing to be treated in this hospital. And then for any specific procedure, including all pain procedures or any other intervention, even the general consent includes the permission for cannulation and urinary catheterization and all sort of procedures. But for any specific pain procedure, we have to have a informed consent, which should be written. A general consent may be oral, even for the GPs, for the general practitioners, or for any clinic. They write on their pad, on their prescription, that OTC is oral consent, OCT, oral consent taken, something like that. There is an abbreviation. That is the requirement of the Healthcare Commission. That is a legal requirement. So if we have to, all of us have to comply with that.
Thank you, Dr. Kiani.
Assalamu alaikum. Thank you very much. My question is directed to Dr. Leena, Professor Leena, and Dr. Athar, who have spearheaded the actual problem. I had a benefit of working in Pakistan for a couple of years. The main problem I faced in pain education is this first slide from Dr. Leena highlights the problem. That is the real problem. So what are our regulatory authorities doing, like PMDC, Healthcare Commission, to have a strict hold on the credentialing, that which clinicians are allowed to practice pain medicine? FCPS is a recognized body, CPSP is a recognized body. How do you see this problem solving in future? Because that is a very practical problem as far as which people are allowed to practice pain medicine.
Let me answer this question. About our actual, the on-site regulatory authority, we can say. We have two regulatory authorities. One is PMDC. PMDC is more concerned with the doctor's qualification, the way they are qualified. And the other regulatory authority, which is the Punjab Healthcare Commission, and I think there is Sindh Healthcare Commission also. So the Healthcare Commission has the authority to have on-site visits and actually see that what is being done in the hospitals or with the patients. And they are actually, Punjab Healthcare Commission, a little while ago, a few months or a few years ago, they did not have any idea that what is pain medicine. So I communicated with them that you have the minimum service delivery standards for specialized clinics, for all sort of clinics, for the hospitals of different sizes, but you don't have any minimum service delivery standards for pain medicine. And then they asked me, what is pain medicine? So I gave them some, then they also have some interaction with Professor Khalid Bashir sir, and asked them, pain medicine kya cheez hai? Or hum kuch unko, we have advised, we have given them the basics of it, but the process of developing the minimum service delivery standards is yet in progress. But all the standards are for any specialized clinic. they have standards for specialized clinics. So those standards are actually can be applied on the pain clinic also. But the issue is that all the pain clinics, they are not registered with Healthcare Commission. And Healthcare Commission cannot force the clinics to be registered with them. They can visit, they can check the quackery in their own different ways, but the hospitals apply, clinics apply for registration with that, and then they go through the process of improving their standards and checking, then giving them a license. So that process is still going on. But we do not have a strict regulatory standards for pain medicine or interventional pain medicine.
Thank you, Dr. Asif.
So, just one more thing that I really wanted to say what in my experience was, pain education, what I did for past 15 years is to start from public because they made a good impact, and nowadays it's very easy. Besides, going on morning TV shows and everything, people can just like do a 30-second clip, a short, brief clip, and just post it on digital media. I mean, even one clip, if one patient can get rid of their pain, would be great. So if we all work together on, just making one clip once a month or something like this, the whole approach, if we work together, will make a big impact. So it would be much better if we organize and, make a team and everything. But public then will be more aware, and that helped me a lot in dissipating the pain awareness in Pakistan. So I'm just sharing my little bit experience. Thank you.
Thank you, Dr. Aga.
Thank you so much. Assalamu alaikum. I want to share my experience also. I'm Professor Dr. Rafia from Nawabshah, very remote area of Pakistan. And recently I conducted a survey in my institute about the awareness of the different physicians from different fields about the assessment and management of pain. And I was shocked with the results when it was come out. Survey was constituting of various questions on various aspects of the assessment and management of chronic pain. And when the result come out, there were only the cut value was 75% of the knowledge they should know, and the result was only 5.2% of the physicians who were working, and they were from various disciplines at my institute. They were aware. They secured more than 75% of the marks. So we need to inculcate the education of pain at the very basic level, at the undergrads as well as the postgrads, and should be inculcated in all the disciplines, not in anesthesiology, not the persons like orthopedics and trauma person. So it should be inculcated. Thank you very much.
Thank you. Please, yes, please, yeah.
I'm Dr. Atif from United Arab Emirates. I work in Abu Dhabi at the moment. So my questions for Dr. Cardoza. She's still here, yeah. So Dr. Cardoza, you said something quite profound during the initial part of your talk, where you mentioned we are paid as individuals and not as teams and that is what you mentioned in the context of being a barrier to setting up interdisciplinary, what's the desirable, goal for us. And you said that is such a big problem. You quite expressively, you said, that is such a big issue, and it is that I do not know even the answer for that. And then later, in later part of your talk, you said, so what's the answer in getting better interdisciplinary services? Because I presume that's kind of that when you said it's such a big issue, that is a reflection of how the healthcare services are organized, and that's not always just by the physicians, maybe being just a very small part of it. Most parts of the world, I would say. So in later part, you said, well, so how do we get better interdisciplinary pain clinics set up? And you said the answer to that is education. And you did not mention the role of the healthcare management. So I'm referring to the access to healthcare or the way healthcare is organized. Because to me it appears like a bit of a dichotomy, I must say. in how you deal with the obstacle to setting up interdisciplinary pain services.
Yeah, thanks for pointing that out. I think so. Education. I think we need to have advocacy as well. I didn't talk much about advocacy, and we need to. In our education efforts, we need to educate ourselves and convince ourselves that this is the way that we should be doing things, that we should be working in interdisciplinary teams. But then we need to move forward and convince the people, the administrators and the insurance companies, the reimbursement systems that exist, which are different in different countries. In my country, because I worked in the Ministry of Health, where we are all paid salaries, I could set up multidisciplinary teams because it didn't matter. We didn't work as individuals. But in the private sector, it's just impossible. It's very, very difficult to do it because there is no money to be made. And the private hospitals then are not interested in setting up services that don't make money for themselves. Because, and in Indonesia, they were also telling us that it's the same problem. It's not recognized in the reimbursement list, you know. You can, a consultation with the doctor is recognized, but not a team management approach, you know. So we need to include that, I think. And that will take a lot of lobbying and advocacy work. I'm not sure how it is in the Middle East, whether it's recognized or not, or whether, you know, but I think that that's a much bigger issue which I, as a pain doctor, cannot really address. We need to do it as a society, I mean, this is one of the roles of associations. I think the Pain Association, maybe, well, IASP will not do something like this, I think, because we don't really work on issues like this, but it has to be something that is done at a different level. So I hope, I understand that, you know, there is this dichotomy, and but obviously when we want to make changes, we have to actually strategize and address the problem at different levels. So I was only talking about the, you know, how to change our own behavior, because when we want to make change, the first thing is changing ourselves, I think.
Due to time constraints, this may be the last question.
Yeah.
Please, go ahead.
Dr. Karzusa, your lecture was amazingly good. What I wanted to ask you, that most of the anesthesiologists are practicing here and they're trying their best to do pain. They're like 30, 40, 50 pain patients with the counseling and interdisciplinary and all those things. If you can like brainstorm, or we can, you know, put a team together, that in a society where already there's anesthesiologists are very less, they're rare, and plus they're doing additional work, how they can do their work more effectively, where there's counseling involved and interdisciplinary team is involved. You know, the time is a big constraint. And obviously, you know, reimbursement is, but, you know, people are sacrificing a lot, you know. They don't care about as much money, they're just trying to help patients. There are a lot of doctors like this. But we need to figure out some way that, you know, people who really want to do pain, how they can work more effectively with all this counseling, because counseling is very important. Thank you.
I just answered that very quickly. I said, think out of the box. Basically, I think we cannot keep doing things that the way that we are doing it, you know, and we really have to have trust in our whole team. So we train a team, and then you let the nurse do the counseling, you let the physiotherapist, and we have faith that they will do the correct thing. Once you train everybody to work on the same, with the same philosophy. So that's the short answer. Thank you.
Thank you, Dr. Cardoza.
Thank you so much, sir. Now I'll request our chairpersons, Professor Ismat Chaudhary and Dr. Salman, to please conclude the session, sir.
Just on this note, I was just saying that, is it possible for IAS to set up a task force for Pakistan to teach and train the multidisciplinary setup, like what, so while you are here, you know, so.
It's up to the Pakistan society to initiate this. We are happy to provide resources.
Okay,
Thank you so much, Dr. Cardoza.
Thank you, Dr. Cardoza. We will do, inshallah. All the presentations were excellent, and very interesting questions are coming. But due to time constraint, we have to conclude this session. And we should go home with some take-home messages from this session. First, we should take pain as fifth vital sign and should be monitored in every hospital where we work. Number two, you know, as all of you know, that pain management is a right of every person, so we should give this right to every person of the population. We should establish acute pain service in our hospital. At least we should start try to start this service gradually. With the time, you will get it, inshallah. And the last, EPM, it's very simple and very important course. We can involve paramedical staffs and junior doctors through training of EPM. So we should follow few things which I learned from all these presentations from the speakers. So thank you very much.
I think that we already had a very elaborate question and answer sessions, but in terms of education and collaboration or making interdisciplinary interaction between different faculties, I think the time is now coming up. Because with the lot of universities coming up, I see the specialty of psychologists also coming up. And obviously the physiotherapy departments are mushrooming like anything, and they have become obviously very popular in the city. But it all needs, if we are establishing pain clinics, we can have coordination with them or incorporate them into one of the clinics and make use of them. Because every other day I come across a student who says, yeah, I'm a psychologist, and obviously the physiotherapy is very popular here and there. And as for learning and teaching, I think in education, Dr. Leena has also been doing a lot of work. Everybody, whosoever is involved in this, they were holding workshops, and that is how that's the way to go ahead. If you look 30 years back, nobody knew about the pain specialty, but now every other person is needle happy, and even the orthopods, the physiologists, physicians and psychologists, they are all doing pain. But we need to incorporate, sit together, make a disciplinary things, and then so that it becomes more established and recognized by the authorities as well. Thank you very much.
Thank you so much, sir, for sharing this session and for giving your remarks. Thank you so much.